Okay, so as an overview for the talk, we're going to talk about distal junctional failure. It's really the inverse of proximal junctional failure in thoracolumbar deformity correction when we're dealing with cervical deformity. I'll talk a little bit about prevention, bone health, selecting the lower instrumented vertebra, risk factor mitigation, but what I think is really important is that it's very much about alignment, like proximal junctional failure in thoracolumbar deformity. Improving the definition, which is the real take-home point I want to get across, and if we have time, some case examples. So proximal junctional kyphosis, we heard great talk in the morning session from Shea Bess, has had various definitions in the literature. So if you look at it, the UIV to UIV +2 or +1, depending on which author you're talking about, can be a change of 10 degrees, 15 degrees, 20 degrees. So there was never really a good consensus. But the literature settled on a fairly arbitrary definition of 10 degrees in UIV to UIV +2, which is arbitrary because it was never really based on any data, any health-related quality of life outcome measures, et cetera, or even revision rates. But it makes sense that people would have this definition because if you're going to put a study together in your institution, you're probably going to have like a couple hundred patients, and if the rate is like 20% in deformity correction, you're not going to have a lot of patients to slice and dice. So rather than going with a definition that's clinically relevant, it's easier to just say, let's go with the change of 10 degrees, right? But distal junctional kyphosis is PJK turned upside down in cervical deformity corrections, and it can eliminate or degrade your correction, which is what you're going for, which is what you're putting this poor frail patient through this huge surgery to accomplish, the deformity correction. So I think the stakes are high and you have to get it right, and you try to minimize the failure. So cervical malalignment has been associated with health-related quality of life outcome measures, as we heard in some of the previous talks. And traditionally, the distal junctional kyphosis angle that we defined was a change in 10 degrees, probably because it was low-hanging fruit and easy to come up with a study. This study, which we published fairly early on in our prospective cervical deformity database experience, had 71 patients, as you can see, and it just looked at successful radiographic outcomes. So not necessarily a correlation to health outcome measures, but just the radiographic outcomes with a shorter follow-up time point. And what we found was that the failure to correct the CSVA was associated with various things, but the number one issue that came up, besides the fact that the revision surgery, concurrent thoracolumbar deformity were confounders, and different drivers of deformity were playing a role, the number one major factor that came out in the multivariate analysis was whether or not the patients had distal junctional kyphosis or distal junctional failure. So this is a really important concept, and early on in our experience, we tried to take a first pass at it, and we did univariate analyses that pulled out osteoporosis, but it wasn't a quantification by DEXA, number of posterior level fused osteotomies, transition rods, secondary drivers of deformity addressed or not, preoperative thoracic kyphosis, all these things came out, and then when we did the multivariate, probably because the power was low, it really just came up with something that didn't make a whole lot of sense, transition rods. And this is in an N of 67, so early on in our experience with our deformity data set. And so it occurred in 24 of the patients within 6 months, because again, we had shorter follow-up, but you can see 24% is a significant amount, maybe even a little bit more than what your experience is in thoracolumbar deformity corrections. And risk factors included metabolic bone disease, more number of levels fused, more osteotomies, transition rods, preoperative lordosis and thoracic kyphosis, failure to address whether or not there's another driver of kyphotic deformity lower down in your patient. This gave us like a basis to work off of. And then Dr. Pashas, who you heard, had some nice data to present on DJK, took a look at it as well and came up with the fact that baseline malalignment predicted the DJK, the more kyphotic the cervical spine was, the higher the CSVA, the more the correction is going to be, the more likely you are to get a distal failure, whether you used anterior-posterior surgery or osteotomies, higher-grade osteotomies. But I think alignment is really, really important. And how do you tackle this? How do you measure alignment in surgery to say, well, I got it or I didn't get it? You can't measure these slopes during surgery, right? It doesn't make any sense. If you look at a bed, you can position that bed and change the slope of a vertebra by just, doing a Trendelenburg, reverse Trendelenburg maneuver. So you can't look at slopes. You can look at relationships like how much lordosis you changed. You can look at that sort of thing. But for a longer construct, for a C2 to T10, what can you look at? And we came up with some in-construct measurements. So this is kind of like thoracic pelvic angle or vertebral pelvic angle analysis, where you can measure this in surgery on a Jackson cradle. So you take a vertical along the back of the LIV, and you can look at that line, whether the patient is prone or standing or upright or freestanding, et cetera. And then you do a centroid to centroid, kind of a simple measurement. And the greater that angle is, the more deformed the patient is, right? And we did an analysis with this in-construct measurement in 84 patients, and the ones that had DJK had higher angles. So this is what the surgeon left the operating room with. And if he left the operating room with that angle measured from C2 to T1, like in a cervical to upper thoracic construct, you can see that they got DJK if it was 10 degrees versus 0. So I'm sorry, this is the patient that didn't get DJK, had a lordotic spine. This patient had a straight spine, so it's 0.035. Versus a patient fused down to C2 to T10, if that angle was 20 degrees, they didn't get DJK, but if it was 31 degrees, they did. So you can use these in-construct measures in surgery to figure out if you've done enough correction, and we can suggest some thresholds that you can look at if you read the paper carefully. But at the end of the day, you need to look at your data, you need to look at your measurements intraoperatively and decide if you're imparting enough correction and you got it right or not. And so this brings us to the crux of the purpose of this talk, which is to define the clinically relevant DJK. What should we actually be assessing as a failure here? And Peter had a nice elegant study that looked at the change in 10 degrees, but also other factors like a change in neurologic factors or whether they had a revision. But we looked at just different angle measurements in this study, and what we considered a traditional DJK was the change in 10 degrees. The severe DJK through a statistical analysis looking at the standard deviation in our population. One standard deviation greater than the mean was 19 degrees. So we kind of picked 20 as our threshold for a more severe definition of DJK. And we assessed whether or not these patients had revision surgery and looked at the sensitivity, specificity, precision, and accuracy of the definition of the severe and the traditional DJK. And this time we had 125 patients with longer follow-up, so a more mature study. 27 patients had traditional change in 10 degrees, and 10 degrees had the more severe distal junctional kyphosis. And if you looked at the baseline parameters, there weren't really any differences in the groups. So it's probably what we're going to end up in the postoperative alignments that are going to bring out the problem here. But the severe DJK were associated with more posterior level fused as well as a more caudal LIV. So maybe if the surgeon wasn't getting the alignment right and going very long, it was going to be a risk factor. Baseline, like I said, no differences in parameters in the three groups, no DJK, traditional, or severe. But postoperatively, the severe DJK patients were much worse in terms of T1 slope minus cervical lordosis, in terms of C2 slope, the related parameter, and CTPA. Looking at clinical outcome measures, the NRS scores, this is from baseline to 1 year. So we have the baseline scores in this first column and then the 1 year and the change and whether or not it's significant. Everyone improved in NRS neck, which is kind of a nice thing. Even if you get it wrong, your patients improve. But the NDIs didn't improve in the severe DJK patients, and they did in the other two groups. And the EQ5D didn't improve in the severe DJK patients. So it implies a clinical relevance to the more severe definition. And then how about revisions? Well, there was a much higher rate for a revision if you had the change in 20 degrees or more, 30% versus 7.4 for traditional, leading to a greater specificity, precision, and accuracy for revision surgery. So in conclusion, rather than just pile on the literature with numbers that don't make sense, we should probably be using definitions that are clinically relevant. And I think that change in 10 degrees may not be so relevant, but change in 20 degrees is going to have more relevance to revision and a greater clinical impact in your patients. This is from Dr. Pashas' study, and you can see a patient pre-op and post-op who probably didn't really have the deformity addressed. If you look at the post-op construct, there might be some lordosis in that construct, but maybe you can play Monday morning quarterback here and say that this patient needed a fusion to the upper thoracic spine. And you can see the different risk factors that came out. This happens to be one of my cases, a drop-dead patient, and you can see there's also maybe something going on in terms of neuromuscular issues, and that's what we're talking about when we're talking about frail old patients, right? They're also neuromuscularly compromised with their poor muscle envelope. They're frail, they have osteoporosis, et cetera, poor substrate. You can see a nice passive correction in the MRI, so we know there's going to be a passive correction, but I chose to go longer in this patient to avoid the problem of having a DJK and with the thoracolumbar coronal deformity as well. I did an EMG intraoperatively and it came out with isolated neck myopathy. Her T-score wasn't bad enough to require bone mineral support, pharmacologic. And intraoperative correction here looks good to me. Postoperatively though, you can see a little distal junctional kyphosis. And you can see it there at 6 weeks. At 3 months, it's kind of getting worse. At 7 months, it's even worse. And what I did at this point was to send her for physical therapy. Her son told me that she wasn't sleeping, she wasn't eating, she had poor nutrition. So we told her to improve her sleep habits, improve her sleep patterns, and do some physical therapy. And you can actually see a regression in her DJK angle. So it's actually improving over time. And she's maintained this alignment despite the DJK and has not required any revision surgery. Here's another one, 68-year-old, flexible dropped head, but a lot of thoracic kyphosis, which was a risk factor in that one study that looked at radiographic failures. If you had a lot of thoracic kyphosis or another site of deformity in your spine and you weren't going to be able to address it in this big surgery, that there was going to be a risk factor for failure. And look at her DEXA, 0.9. So she's not osteoporotic, but this is the case that I alluded to earlier in the day where I was putting in screws in T10 and it was absolutely horrible bone. So despite bracing her, there's the intraoperative view. She failed distally, catastrophically, not with any neurologic compromise, but you can just see that the alignment has completely degraded and been eliminated, the realignment potential here. And so eventually she required a revision, but at the revision, before the revision, I sent her for the quantitative CT, and what the DEXA didn't pick up, the quantitative CT clearly shows that she has very poor bone with the trabecular bone concentration of 78.6. If it's not over 120, you shouldn't feel super comfortable without placing them on some kind of bone augmenting agent. And in this case, we gave her 3 months of teriparatide. Postoperatively, we braced her and did a big long C2 to the pelvis fusion for her, which improved her alignment, but left her with significant lumbar and thoracolumbar stiffness. So DJK is unfortunately very common in cervical deformity surgery, as you heard from Dr. Pashas and some of the other studies that we presented. But I think you got to optimize the bone health. You got to select your LIV very carefully. Risk factor mitigation, try for soft landings distally. I use 5.5 titanium rods and no bigger. Alignment, alignment, alignment. And use a new definition, not one that's going to be clinically irrelevant in 75% of the patients in the cohort. So revisions for DJK, consider that quantitative CT and get a better LIV. Thank you.